Thanks for the invitation to speak today. So here are my disclosures, and the first disclosure is for a study that I'll be describing later in this presentation. And so the objectives for this presentation are to describe some research showing current gaps in treatment for opioid use disorders and hepatitis C among people who inject drugs. And then I'm also going to introduce an ongoing study called the HERO study that's comparing models of care for people with hepatitis C who inject drugs. And so this slide is very familiar to you guys, no doubt. In the United States, hepatitis C is primarily transmitted through injection drug use, and other developed countries as well. And I always kind of get a kick out of showing this odds ratio from the first NHANE study, which showed the association of injection drug use and hepatitis C was 149. Confidence interval from 45 to 494. So obviously it's a very strong risk factor for hepatitis C. So the prevalence of hepatitis C among people who inject drugs in North America is estimated to be 73%. And this is in contrast to HIV, where the prevalence is approximately 15% among people who inject drugs. So clearly this is a big problem among people who inject drugs. As you're well aware as well, epidemiology of hepatitis C is really being transformed recently, and that's primarily because of this epidemic of opioid use. Previously, the prevalence had been highest among baby boomers, but we're seeing increased incidence among young adults and also people who live in rural areas. And so we know that the good news is that we have very effective medications for treating opioid use disorders. And I know you've had a lot of talks on this previously by Joe and other people. So we've got opioid agonist therapies, buprenorphine and methadone, as well as naltrexone, opioid receptor antagonist. And that comes both as a short-acting and extended release. So the studies do show that opioid agonist therapies are effective in decreasing craving, illicit opiate use, and decreasing injection drug use, and as a result, associated with a lower incidence of hepatitis C among people who inject drugs. And so I published a study with colleagues in San Francisco looking at the association between OAT and hepatitis C incidence among young injection drug users in San Francisco. And we showed that OAT was associated with about a 60% reduction in incidence over time. And around the time that that study was published, there were two other studies from other continents, from Canada and then Australia, that showed similar protective effects from OAT. So there's really strong evidence right now that OAT does reduce incidence of hepatitis C among people who inject drugs. So we know we have these effective medications for opioid use disorders and hepatitis C, but the question is, do people who inject drugs really have access to these medications? So with colleagues here, we did a study to look at the utilization of buprenorphine and methadone among opioid users who inject drugs in the Seattle area. So this study utilized data from the CDC's National HIV Behavioral Surveillance System from 2015. So NHBS is an annual survey that's conducted among HIV risk groups, and every 3 years it's focused on people who inject drugs. So they use respondent-driven sampling. And the original survey had a single question that asked about drug treatment. It just said, have you received any treatment for addiction in the past year? So in our local survey, we decided to add questions that asked specifically about OAT. So the questions asked specifically if participants had received treatment with either methadone or buprenorphine in the past 12 months. So our sample was adults in the Seattle metropolitan area who'd injected drugs and who also reported opioid use, because we wanted to look at individuals who are eligible for these treatments. So this is what we found. Among the sample of 487 individuals, the majority, 70%, reported that they had not received methadone or buprenorphine in the past year. 27% said that they had tried to get treatment with methadone. 27% said that they were treated with methadone in the past year. 15% had tried to get treated but were unable. And only 5% reported that they had been treated with buprenorphine in the past year. And double that said that they had tried to get treatment with buprenorphine but were unable. So it seems that we have some major gaps in access to treatment. So we're currently doing a study to look, using the same data set, to look at access to treatment for hepatitis C. So the national survey did have questions about hepatitis C testing, and the survey itself performed antibody testing among all participants. The local survey had additional questions that were added, asking about awareness of medications and treatment and barriers to treatment. So we're looking at the same sample, although it's not restricted to opioid users this time. And the primary outcomes of interest were really looking at the steps along the continuum of care. So this is what we found. We have a sample of 525 individuals, and of those, the majority, 84%, did say that they had been tested for hepatitis C at least once. And of those who were tested, reported being tested, 60% said that they were told that they had hepatitis C. Now, when the survey did testing, and this was at the end of the visit, they found that in reality, 66% did have a positive screening test. So there were some individuals who did not know that they were infected. However, this is, it's less than has been reported for some national surveys like NHANES. So interestingly, I thought, so the individuals who reported that they had been tested and were infected, we asked if they'd heard of DEA treatment, if they'd ever been treated with any medicines, and if they'd been treated specifically with DEAs. And so the majority said that they had heard of DEAs, which I thought was impressive since this is 2015 and they'd only been available for a couple years. But when looking at how many had been treated, only 16% had ever been treated and 6% reported being treated with DEA specifically. So it looks like we've got a big gap in sort of the proportion of receiving treatment. So we did ask individuals who had not been treated why they were unable to get treated. So there were 15 individuals who said that they wanted to get treated with DAs but were unable to. And the top three reasons were that they didn't have a regular doctor, or their doctor said treatment wasn't needed, or they saw a specialist and they were not offered treatment due to their drug use. So unfortunately, we do know that there are barriers to receiving treatment among people who inject drugs. And so there was a study that was published in 2016. It was a survey of Hep C providers who were specialists. This was a survey that was conducted at the AASLD conference. And among that sample of 108 providers, they found that only 15% were willing to prescribe DAs to active injection drug users. And the top concerns that were cited as reasons for why they would not prescribe were concerns about non-adherence and reinfection. So what do we know about adherence rates and reinfection among people who inject drugs? Well, the studies to date suggest that there may be nearly equivalent cure rates among people who inject drugs compared to non-injection drug users in the DEA era. However, I will caution that most of these studies have been conducted in the setting of clinical trials, and we really need more data on real-world settings. So the reinfection rate that is quoted out there is 4.6 per 100 person years in this recent study, the C-EDGE COSTAR study. And in theory, we can prevent reinfections. So this should be something that is we can impact upon, we can intervene upon. So there are research needs, obviously, in this area. I think we need research to expand, to develop and test models of care that can expand access to medications, both the DAs and opioid agonist therapy, and optimize adherence among people who inject drugs. But also we need data from real-world settings to inform care. We need more data about the barriers that are out there, both to adherence and accessing medications. We need more data about whether non-adherence really impacts outcomes in this DA era, since the medications are so good. We also need more data about reinfection rates in this population and how we can prevent reinfection. So I'm going to tell you a little bit about the HERO study, which is an ongoing study that I'm involved with. It's a national study that's funded by PCORI. It's taking place in 8 different states that are listed there. We are enrolling, the plan is to enroll 1,000 active injection drug users, and this is defined by having injected within the past 3 months. And it's assumed that 600 will initiate treatment, and treatment is with sofosbuvir or vilpatasvir. So treatment is provided on site either at community health centers or at methadone treatment programs. And here in Seattle, we're partnered with Evergreen Treatment Services. The outcomes that we're looking at are initiation, adherence, completion of treatment, sustained virologic response, resistance, and reinfection. And individuals are being followed for 2 years for reinfection. And there are many stakeholders who are involved in this study, including CDC. So this is the schematic of the study design. We're enrolling all genotypes. And enrolling both persons with and without HIV. So individuals are randomized to 2 different models of care, either this modified directly observed therapy, which in the methadone clinic consists of getting your hepatitis C medications dispensed with your methadone. And in the community health center setting, it consists of using a smartphone app, which allows patients to download videos of themselves taking their medication daily. So they can be randomized to modified directly observed therapy or to patient navigation. And here in Seattle, we're partnered with the Hepatitis Education Project, who are providing us with case managers who are doing the patient navigation. So individuals have up to 12 weeks to initiate treatment, and then they're followed through treatment. And then, as I said before, they're followed for 2 years to look for reinfection. We're testing them every 3 months. So these are our enrollment numbers, and I'm very happy to say that we're nearly done with enrollment. Our goal is to treat 75 individuals, and we're currently up to 70. And unfortunately, I don't have outcomes that I can report here today, but this is a quote from a patient, just to get a sense of the impact of this study on the patient level. Patient said, "I can't tell how grateful I am to the team of nurses, doctors, and HERO staff that convinced me that treatment was the way to go. I would admit I'm not very responsible when it comes to taking medication, so having the support of the HERO teamsters, it made my journey to a healthier and better lifestyle that much easier. I used to think it was going to be a major inconvenience having to take all sorts of medications and all. However, it turns out it's only 1 pill for several weeks and then follow-ups thereafter, which is not much to put up with considering we're talking about your health." So we found that this work really gratifying, and this patient population very appreciative of the treatment. So in summary, access to medications for opioid use disorders and hepatitis C is suboptimal for people who inject drugs. And as I showed you in the Seattle area, only 30% reported past year treatment with OAT, only 16% reported ever being treated for hepatitis C. So we've got a long way to go. We need more research to establish models of care that can improve access and adherence to medications for this population. And hopefully the HERO study, which compares 2 different models of care, will provide some valuable information on relationships between adherence, hep C treatment outcomes, and reinfection rates among people who inject drugs. That's it.